Dear friends, today I am going to share a case of Genu Varum Shortening. She's a 24-year female and right lower limb is involved, as you can see in the pictures. She has some congenital issue due to which it happened, and there is history of some surgery at the age of 5 years. Now she's having shortening, she's having fatigue, she's having limb, and there is deformity of the right lower limb. The Tendoachilles Grade 5 power. Dorsiflexors of the ankles, they are slightly weak. There's no FFD of the knee. She has brought her own frontal plane scanograms. And let us calculate the deformity. We use the method of map the ABC. What is this? M stands for measure the mechanical axis deviation. MAD. From center of the hip to the center of the ankle, if we draw a line, we find the knee is laterally placed, which means varus is there. After this, we come to next step, analyze the angles, where from the deformity is coming. And once we analyze the angles, we find that MLPFA is 85 degree, which is normal. MLDFA is 96. MPTA is 81. LDTA is 112. What does this mean? This means upper end of the femur is having normal angle, no hidden deformities. The lower end of the femur is varus. There is varus also at the upper end of the tibia. There is varus also at the lower end of the tibia. So P, map, M has been done, P, A has been done, and now we come to the P. Pick up the deformed bones. So lower end of the femur is deformed, upper end of the tibia is deformed, lower end of the tibia is deformed. The deformity is coming from 3 places. And once that has been done, then we come to the, from MAP, map the ABC, A. Where is the apex of the deformity? Where it is located? And what kind of bone cuts or the level of the osteotomies will be there, and how we will correct it? Gradually, acutely, or some part acutely, and rest of that gradually. A is the apex. The apex of deformity of the lower end of the femur is 10 degree and it is at the joint level. Similarly, at the tibia, it is 10 degree varus. It is also at the joint level, upper end of the tibia. Now we come to the lower end of the tibia and it is 22 degree varus at the level of the ankle joint. Then we come where the bone cut should be there, B, and what should be the level of osteotomy. The osteotomies, they definitely, as you know, cannot be done at the level of the joints. So we are trying to do them as near to the joint without disturbing the joint. It is in the lower end of the femur, in supracondylar area, upper end of the tibia, HTO, high tibial osteotomy, and supramalleolar osteotomy. So we are doing 3 osteotomies. One at the lower end of the femur, other end, the upper end of the tibia, another at the lower end of the tibia. Let us slightly go back to the first step. The patient had brought the scanograms, and if we really find what was the first step, the patella was not centered in this scanograms, but we did the calculation. Let us see now what I did. I did my own scanograms, and now I placed position of the limb such that we have centering of the patella like this. Secondly, we have kept a marker so that we can exactly know the length issues. Then we have about 2 centimeters raise the short lower limb before doing the scanogram. So all the three things, patella centered, kept a marker, and raise the lower limb. So from the scanograms which the patient had brought, now we have shifted to my own scanograms with these three things. And let us see what happens. This is very important because most of the time patients, they come with their own scanogram. They are not ready. Even we are not ready to do calculations on them. So we have to see these things. And now let us calculate the deformity again. Another benefit of that is having my own scanogram, that these are the DICOM images. And on the Horus software, we can accurately and precisely do the drawings, find out which are the angles, and also find out the level of the Ilizarov operators, where is the cora, what should be the size of the ring, what should be the size of the chance pins, etc., etc. So again we calculated, and now we have calculated on the my own scanograms, and here we find MLDFA is 89. Earlier it was 96. Now it is 89. What does that mean? That means lower end of the femur is normal, and we are having a deformity at the upper end of the tibia and lower end of the tibia. Doing my own scanograms and precisely measuring the deformities, I have now come to know that lower end of the femur is not involved. And I went one step ahead to calculate the deformities on the 3D CT scan. I will show certain slides. Why do we do 3D CT scans? One thing, this is very precise than even the your own scanograms. And you are doubly sure, and you might have access or might have no access to the scanograms, but these days 3D CT scans, they are available everywhere. And this kind of 3D CT scan you can have for the lower limbs. And if you don't have scanograms, even then you can exactly measure where the deformities they are there with the help of these 3D CT scans. This is one thing. Second thing is, you can exactly midline patella can be achieved. And this is how we take frontal and sagittal plane full length views on the CT scan. This is how the lateral is being taken. Sagittal, the condyles, they will overlap. And once they overlap, like this, now this is the true medial and lateral sagittal plane kind of scanograms on which you can do all kind of calculations. I'll again show you. This is how the AP view is taken when the center of the patella is right in the middle of the condyle. Once more, I'd like to show you like this. We rotate the picture and till the center of the patella. Now, this is the true AP view frontal plane, hip, knee, ankle, all in one. And for true sagittal plane, the condyles, they should overlap, femoral lower condyles should overlap each other like this. And once they overlap with each other, then we take the full profile, sagittal, medial side, as well as then after that, we can take the lateral side. We presume that sagittal plane is okay. But here in the same 3D CT scan, we can really find out, is there any sagittal plane issue or not? This is the advantage of 3D CT scan. What else? It tells you exact rotational issues as well. We presume there will not be any rotational issue, but we must be precise in doing any deformity correction, whether it is frontal, sagittal, rotational issues, they are there or not. So here we found that anteversion of the femur was 14 degree, which was normal, as well as there was no rotational issue with the tibia. So on this, we can really plan very exactly the length of the Ilizarov apparatus, first corora, second corora, level of the osteotomy, how much far off that should be there from the joints. In my city, it is about 2,000 rupees, and we get 3D CT scan done, and precisely we can come to know all the angles, rotations, frontal plane, sagittal plane issues, and do the calculation. We are doing this thing for last about 6 years, and it is very helpful. Another thing is the same images, the DICOM images, they can be used for 3D model formations. What will be the use of that? You can exactly see the deformity in your hands, and you can really know what kind of thing you are going to deal with. This thing is especially when the multi-apical deformities, there are multiple deformities of the lower limb. There is also rotational issues. You want to do multiple osteotomies. This is very helpful. Another thing is you can really see the joints. You can really see the bone you are going to do osteotomies or some kind of corrections. And you can really peep into the joints. And another advantage is you can have lateral or inner and outer MPTA. Sometimes it is different. MPTA, the posterior proximal tibial angle sometimes is different on the medial and lateral side. And you can exactly find out what kind of things you are going to deal with. Then you can also see the relationship of the bones, joints with the nearby neurovascular structures, and then can plan your shunt pins, your wires accordingly. You can also plan the path of osteotomies which you are going to do. So dear friends, you can in future make it a routine also. If you do not have access to the 3D to the plane scanogram, to have a 3D CT scan and find out these things. Then going on to pre-operative Ilizarov rings, blocks, and hinges. Pre-operatively, two separate blocks they are used, and both are connected with the hinges. Proximal for the HTO, high tibial osteotomy, and distal hinge for the supramellular osteotomy. So two separate blocks which have been joined by a single, which have been joined with the help of threaded rods, and two hinges they are there in both the blocks for doing osteotomies, corrections. This is how this will look on the deformed lower limb. We also note down on the page what is the initial distance, what is the initial angles, where from we started, so that in future we come to know how much was the calculations angle they were corrected on the table or off the table. Here, one thing more which we did was that the hinges they were placed one hole medial in the front and one hole lateral in the back of the ring. What does that mean? The center of the hinge was not the center of the ring. Center of the ring, instead of being the center of the ring, we took the hinges one hole front and one hole behind on the other side. Why this was done? So that we can have the position of the hinges and without disturbing the centers of the rings which have been connected with the nut and bolts. Without disturbing them, we can have the hinges in this plane. So center of the ring now is one hole front on the anterior side and medial side. Similarly, center of the ring now is not there on the nuts and bolts which are connecting the two rings. What are the operative steps? We do the markings, patella, tibial tuberosity, anterior border of the tibia, malleoli, and the vessels. First of all, we do the fibulectomy. Then the placement and adjustment of the ring block is made. And now we do not take the center of the ring as the center of the placement of the block. Instead of that, we take these hinges as the center of the ring, so that we can, as we have shown in the previous slides, we adjust them and start doing the placement of the supramalleolar. First shank pin is being placed, and it is done by pre-drilling on a wire. And first supramalleolar shank pin is placed by precisely being parallel to the joint, and with the help of a wire, then drilling over the wire, then passing the exact shank pin. After that, we pass the uppermost shank pin by pre-drilling on the Steinman pin with the 4.5 mm, and after that, we place the shank pin of the required length, appropriate lengths. After that, more of the shank pins, they are passed in the proximal part of the tibia by pre-drilling with the help of a Steinman pin. And once that has been done, then we come to the lowermost shank pin placement. Before that, we do pre-drilling with the, in this case, as you can see, with the help of Steinman pin 4.5. Once that has been done, two wires they are being passed, or with 3.2 millimeter wires, 3.2 millimeter drills will be placed, and over that path we can place the shank pins, the thinner ones, and tibial shaft shank pins, they are then placed. So the assembly has been put, and now it is ready, and we can go ahead for the osteotomies. For supramalleolar osteotomy, first we adjust the path of the osteotomy by passing different wires and see them. Once the wire has been put in on the desired path of the osteotomy, we start drilling over that wire. Once drilling has been done, then with the osteotome, we complete the osteotomy. This is how it has been completed and corrected as well over the end. Similarly, for HTO, we decide the path of the osteotomy by passing a K-wire. Over that, we drill so that the path of the osteotomy is ready. Over that, we do with the help of osteotomy, we complete the osteotomy with the help of osteotome in the frontal as well as in the sagittal plane. On about after 2 or 3 days, we find out what is the full length X-rays they are done, and we found there is 5 degrees of varus, which was corrected on the 6th postoperative day with the help of a hexapod. All the corrections they were made on the table. We must do sagittal plane evaluation as well, because sometimes we can create unwanted deformities in the sagittal plane. So here we did the full X-ray of the tibia, and we found that PPTA was 83.7, which was normal. On the 6th postoperative day, this the hexapod for a precise correction of the HTO. And 3 months postoperatively, these are the full-length X-rays, frontal plane, and this is 4th month postoperative dynamization has been done, and number of the shunt pins, number of the rings have been reduced, and this is the time when the patient is happy. We get the reviews, yes, all my problems, they have been solved. I'm very happy, and this is how this was our documentation purposes, the video of the patient that she is happy. After 7 months, these are the pictures, frontal plane as well as sagittal plane. And this is before and after the surgery. And you see the patients, they are very comfortable, and once they are on the Ilizarov, they can walk properly, and this is before and this is after 7 months after the removal of the apparatus. Thank you very much for your patient hearing, and I hope you have enjoyed this, and might be certain things, especially the message is you should see that the scanogram which you are dealing with is appropriate. If it is not, you can do your own scanogram, and you can confirm that with the help of 3D CT scans. And if you do the proper planning, the deformities, they can be very well dealt with. Thanks very much for your listening and seeing this video.